Mahmoud Nady, مدرس الكلى. Our talk today is about cardiac surgery associated AKI. We will go through the BOKI-IRAS joint consensus report that was released in May 2023. It's a joint consensus report between the Preoperative Quality Initiative and Enhanced Recovery After Surgery Cardiac Work Group. Our objectives today will be introduction, definition. We'll start by the introduction. Acute kidney injury is a serious complication after cardiac surgery, the second leading cause of AKI in intensive care unit. The cardiac surgery associated AKI as high as 40%. Approximately 3% of patients require at least temporary renal replacement therapy. Patients with severe AKI are confronted with 3 to 8-fold higher preoperative mortality, prolonged hospital ICU stay, hospital stay, and increased cost of health care. Approximately 25% of patients with AKI will suffer from chronic kidney disease after 3-year period. We will go through the consensus as we go. The first recommendation was that health systems are recommended to demonstrate deliberate commitment to optimize kidney health and outcome of patients at risk for or who develop cardiac surgery associated AKI. About the definition, according to cardiorenal syndrome classification, cardiac surgery associated AKI can be classified as type 1 cardiorenal syndrome, acute cardiorenal, which is characterized by rapid decline of cardiac function leading to AKI. But despite this theoretical framework, no consensus on the definition of cardiac surgery associated AKI, and the definition and diagnosis is on the literature are derived from the AKI diagnostic criteria. The diagnostic is the rifle or AKI or KDIGO, dependent on the serum creatinine and urine output mainly. As regards the pathophysiology, while the term AKI summarizes a syndrome of acute organ damage and its function, with various pathophysiology, the subset occurring after cardiac surgery termed cardiac surgery associated AKI. And because characterizing the different entities of AKI have become increasingly important, since emerging evidence suggests that each type has unique molecular and diagnostic features that will affect the treatment. The theories about the pathophysiology of cardiac surgery associated AKI are mainly these 5 entities: renal hypoperfusion, reperfusion injury, inflammation and oxidative stress, nephrotoxins, metabolic and neurohormonal activation, and genetic polymorphism. About the pathophysiology, the cardiopulmonary bypass may lead to hemolysis, production of free radicals that may lead to vasoconstriction. Inflammatory and oxidative stress may lead to activation of inflammatory mediators that will lead to vasoconstriction. Low flow, low pulse, or non-pulsatile perfusion with hemodilution, hypothermia, and the bleeding complication. Neurohormonal factors or activation of RAS system and sympathetic system will lead to vasoconstriction. All of this will lead to reduced renal perfusion that will lead to AKI. Also, there is embolic factors and genetic predisposition, nephrotoxic agents, drugs or contrast. Extracorporeal circulations that occur during the surgery will cause ischemia, reperfusion injury, opening of mitochondrial permeability transition pores that will lead to cell injury and consequently AKI. About the risk factors, there is patient-related risk factors and surgery-related risk factors, preoperative, intraoperative, and post-operative. The main issue in the preoperative risk factors are female gender, age, albuminuria, and other comorbidities as hypertension and diabetes. Intraoperative risk factors: cardiopulmonary bypass time, non-pulsatile cross-clamp time, hemodilution, transfusion load, and hypothermia. About the post-operative risk factors: hypovolemia, hypotension, and sepsis. Patient-related and procedure-related. There is many risk predictive models that were postulated for assessment of the risk for the cardiac surgery AKI among the previous years, but none of them validated enough to be used. The second recommendation is every patient is recommended to undergo a kidney health assessment before cardiac surgery, which include assessment for proteinuria, serum creatinine concentration. The third recommendation was leverage of electronic medical records to timely identify patients at risk for cardiac surgery associated AKI for prompt further evaluation. These are the risk factors presented in the joint consensus. Now we move to the diagnosis. About the diagnosis, the diagnostic criteria for AKI, rifle, AKI, and KDIGO are the used criteria. but there is further measures we can do to confirm or predict the cardiac surgery associated AKI as the biomarkers and point of care ultrasound. Early recognition and diagnosis of AKI are critical because prevention before clinical manifestation may provide better outcome than treating patients with established AKI. However, current diagnostic criteria are not suitable for timely diagnosis because neither decrease in urine output or increase in serum creatinine recognized early. In cardiac surgery associated AKI, several biomarkers have been identified and validated. Several have been identified, but minor have been validated. The validated in our consensus was the TIMB2 over IGFBP7 ratio. There are novel candidates as biomarkers for the cardiac surgery associated AKI as the renin, free hemoglobin, CCL14, and this marker. One of the recommendations was the use of urinary biomarker as a part of care bundle to enhance kidney health evaluation and reduce cardiac surgery associated AKI in the post-operative period. This is the model presented in the consensus. It's related to the biomarker we mentioned before. If the ratio is less than 0.3, there is a low risk for cardiac surgery associated AKI. Between 0.3 and 0.7, moderate to high risk. If it's above 0.7, we must call the kidney team. There are some precautions كده we may take in each part of this each part يعني كل جزء من الحاجات دي في حاجات precautions معينه المفروض ان احنا نعملها على حسب هو low risk ولا moderate to high risk ولا محتاجين ان احنا نجيب النفرولوجي team. We move to the point of care ultrasound. There is arterial profile and the venous profile may be used. In the arterial profile, we focus on the renal artery. Renal arterial resistance index is a method of measuring parts of blood flow which reflects the blood flow resistance caused by the distal microvascular bed at the measurement site. About the intraparenchymal renal resistive index variation, its index derived from the RRI. Its percentage of RRI decline from the baseline after abdominal compression about 10% of the body weight of the patient. When we move the venous profile, we use the renal, hepatic, and portal veins in the focus ultrasound using the venous profile. Patient of intrarenal patterns of intrarenal vein flow has been found to strongly associated with adverse clinical outcome inadequately predict increase of risk of perioperative AKI and mortality. Specifically, portal pulse rate calculated بالmeasure دي أكثر من 50% considered the sign of venous congestion, and it was found to be independent predictor of cardiac surgery associated AKI along with pattern of intrarenal venous flow. This is a physiological pattern and mild venous congestion, severe venous congestion in the renal vein, hepatic vein, and portal vein. The next recommendation was the use of point of care ultrasound to augment the evaluation of post-operative intravascular volume status, depending on the last slide we talked about. Now we move to the main issue, which is the management. Actually, it's not management of cardiac surgery associated AKI, preventive method more than treatment. The management of patient with cardiac surgery associated AKI requires multifaceted approach that include early diagnosis, monitoring of renal function, and preventive and therapeutic interventions. Interpretation of all information, choice of hemodynamic target, and intervention applied to the patient with cardiac surgery associated AKI at any moment of time, and assessment of response to therapy all remain an art rather than a science. Management of patient with cardiac surgery associated AKI will be subdivided into three parts: pre-operative strategies, intraoperative strategies, and post-operative strategies. As regards to pre-operative strategies, about the pharmacological intervention, many drugs have been tried before to be evaluated and also abandoned, and some of them still in use till now. Corticosteroids, albumin, statins, N-acetylcysteine, sodium bicarbonate, and mannitol, furosemide, and phenoldiazepine. This drug is alpha-2 adrenergic receptor agonist with sedative, analgesic, and antisympathetic effect. Studies are contradictory in this part. Some say it improves the outcome, and some say it worsens the outcome and shouldn't be used. Atrial natriuretic peptide have been reported to inhibit RAS and sympathetic nervous system, both of which contribute to the pathophysiology of cardiac surgery associated AKI. Low dose atrial natriuretic peptide is helpful for us. High dose atrial natriuretic peptide will cause deleterious effects. Levosimedan is a cimedan is a sensitive calcium sensitive inotropic vasodilator commonly used to treat low cardiac output after cardiac surgery, and it's believed to have antioxidant, anti-inflammatory, and anti-apoptotic properties that found to significantly attenuate ischemia reperfusion injury. About optimizing of pre-operative medication, about ACE and ARBs drugs, it's still controversial till now when to withdraw this medication. Nephrotoxins should potentially be avoided during perioperative period of cardiac surgery. About rehabilitation, cardiac rehabilitation program should be installed on the patients before cardiac surgery, including education, nutritional optimization, exercise training, social support, and anxiety reduction. The current evidence mainly focus on the role of preoperative cardiopulmonary and muscle rehabilitation in reducing hospital stay and the pulmonary complication after cardiac surgery, not with cardiac surgery associated AKI. The next recommendation was to allow the consumption of clear liquid up to 2 hours before general anesthesia to reduce the risk of dehydration post-op. Intraoperative strategies that may be used as a preventive measures, optimal target of mean arterial pressure. The normal range of renal autoregulation is between 75 to 160 millimeter mercury. Mean arterial pressure is usually below the lower limit of this range during cardiopulmonary bypass. However, optimizing the mean arterial pressure during cardiopulmonary bypass wasn't shown to be associated with reduced incidence of AKI or chronic kidney injury. As regards inotropics and vasopressor support, inotropic agent may be used to improve renal perfusion in case of low cardiac output, and vasopressor may be used to increase renal perfusion pressure in case of hypotension. As regards fluid, diuretic, and goal-directed therapy of the fluids and the diuretics, these three main points should be known. Both excessive accumulation of extracellular fluid and intravascular hypovolemia can contribute to AKI. Type of fluid is very important, as hydroxyl ethyl starch is associated with increased risk of AKI. In terms of colloid, perioperative chloride, liberal intravenous fluid may lead to hyperthalamic metabolic acidosis. When compared to Ringer, 4% albumin solution for priming cardiopulmonary bypass and volume replacement solution can't reduce the incidence of AKI. Diuretics are not recommended for prevention of AKI, but loop diuretics may be used for the management of volume overload. Loop diuretics may reduce postoperative creatinine clearance, whereas aldosterone agonists spironolactone increase the risk of cardiac surgery associated AKI. The next recommendation was no prophylactic or otherwise routine use for diuretic therapy in the context of cardiac surgery associated AKI. Goal-directed oxygen delivery in the cardiopulmonary bypass. There is a cardiopulmonary bypass bundle should be attempted during the cardiac surgery. With the oxygen delivery should be maintained above 300 milli per minute per meter squared during cardiopulmonary bypass to reduce the incidence of AKI post-op. About transfusion of bagged RBCs during the operation, current guidelines recommend infusion of bagged RBCs if hemoglobin drops below 6 grams per deciliter, or hematocrit value maintained between 21 and 24% when the oxygen delivery percent is 273 milli per minute per meter squared. Restrictive transfusion pattern strategy versus liberal transfusion pattern strategy, debatable till now. About remote ischemia intraoperative strategies, there is a remote ischemia preconditioning. It's a maneuver that could be done after initiation of anesthesia, general anesthesia, but before the start of the operation or the incision. It's techniques that artificially induce repeated transient ischemia perfusion to distal limbs, aiming to protect against subsequent ischemia damage to the sensitive organs. It depends on DAMBs. The next recommendation, use of cardiopulmonary bypass bundle in patients cardiac surgery will minimize cardiac surgery associated AKI. About the bundle, it includes many parts, but avoiding severe anemia, optimizing glycemic control, avoid hyperthermia, avoid excessive ultrafiltration, and perform goal-directed perfusion of oxygen. The next recommendation, preservation of adequate intravascular volume in the setting of dynamic fluid shift and cardiopulmonary compromise. That will help to prevent post-operative cardiac surgery associated AKI. No use of excessive ultrafiltration during cardiopulmonary bypass. No use, it means it will not affect the outcome. Use of Use of individualized perioperative goal-directed therapy to reduce the incidence of cardiac surgery-associated AKI, goal-directed therapy in oxygen delivery and in hemoglobin targets. In the post-operative strategies, we only use the KDIGO bundle of care. KDIGO guidelines recommend a variety of supportive measures, including discontinuation of nephrotoxin, possible optimization of fluid status, hemodynamics, consideration of functional hemodynamics, urine output, avoiding hyperglycemia, and consideration of alternatives to radio contrast procedure. KDIGO bundle strategy significantly reduce the incidence of severity of AKI in patients in cardiac surgery-associated AKI. The next recommendation, development of new KDIGO stage 2 or 3 cardiac surgery-associated AKI should prompt referral to long-term follow-up, and development of new persistent dialysis-dependent cardiac surgery-associated AKI should prompt multidisciplinary review similar to other serious adverse hospital-acquired conditions. To summarize, the perioperative quality initiative and the enhanced recovery after surgery cardiac society joint consensus in May 2023. Treatment options are ineffective at circumventing kidney injury and have made prevention and early identification of AKI the primary focus. Furthermore, there is growing body of clinical evidence that the application of bundled preoperative interventions and the perioperative mitigation strategies can ameliorate the incidence of cardiac surgery-associated AKI. In those patients who developed cardiac surgery-associated AKI, interventions promoting the early recovery of renal function have been associated with improvement in long-term survival. Lastly, there is a Society of Thoracic Surgeons, Society of Cardiovascular Anesthesiologists, and the American Society of Extracorporeal Technology guidelines for prevention in 2022. There is some difference, but we will conclude three only of them. Adult cardiac surgery AKI, phenol-dopam may be reasonable to reduce risk of as long as hypotension is avoided, but about dopamine and mannitol, there is no use of using them. Thank you.
شكرا دكتور محمود. انا بس عايز اقول يعني كومنت سريع كده بس على الموضوع ده. يعني زي ما احنا شايفين كده تو سمرايز ان احنا الموضوع كله يتلخص في الايرلي ديتكشن. خلاص هو ده هيحدد لانه وانس الاي كي اي از استابليشد خلاص المانجمنت مش هيبقى ايه احسن حاجه. فهو الكلام كله على الايرلي ديتكشن والايرلي او الامبلمنتيشن اوف كير باندلز ايرلي انف. بس حابب بوينت حاجتين مهمين. انتوا عارفين دلوقتي بدا يبقى في افيلبل اي اي تولز كتيره ديزايند او علشان تعمل الايرلي ديتكشن ده، و اتس يعني it has been proven ان هو تقدر تدينا at least 48 hours advantage for early detection of AKI. فده هيبقى حاجه المفروض ان احنا نسعى ان احنا تو implement. كمان زي ما احنا شايفين في بعض البايو ماركرز ممكن بقت موجوده وفي منها دلوقتي حتى commercially available، فده ممكن يساعدنا برضو for early detection for الانسولين acute kidney injury، وده ممكن يساعدنا ان احنا نعمل الكير باندل recommended علشان to minimize the risk of AKI. النقطه الثالثه زي ما احنا شايفين حتى بدا يبقى الكلام عليها في الجايد لاينز، موضوع البوينت اوف كير الترا ساوند اللي هو بدا يبقى متاح دلوقتي. ده هيدينا فرصه كويسه ان احنا لما نأكواير السكيل دي ان شاء الله وتحضروا معانا ورك شوبس ان احنا نبقى في اكتفلي قادرين ان احنا كل يوم نيفالويت الكيدني بسرعه ونشوف الهيموداينامكس بتاعتها والبرفيوجن بتاعها، لان احنا عندنا مشكلتين ممكن بيحصلوا. احنا ما بين الشق اللي هو ان احنا عندنا فلوفر اوفرلود وكونجستيف نيفروباثي، وانت في الحاله دي انت عايز تعمل انلودنج للمشكله الكيدني، وما بين انه الكيدني از هايبوبرفيوزد نتيجه الهيمودايناميك انستابيليتي، والحاجتين علاجهم عكس بعض والحاجتين بيحصلوا بسرعه جدا. فاحنا الفكره ان احنا نبقى لو في عندنا السكيل ان احنا نقدر ان احنا بسرعه دايما او بشكل دوري نبص على الكيدني اكتفلي، ده طبعا ممكن يساعد ان احنا يوبتمايز المانجمنت بتاعنا.